Um, I probably have drawn the short straw because, as Neil said, the largest volume. Thanks to Baxter for sponsoring this symposium. I probably have drawn the short straw because, as Neil said, the largest volume of fluids prescribed in hospital practice are probably around maintenance fluids, but there's very little evidence to say that one fluid is better than the other. So I'm going back to first principles, and we talk a little bit of physiology and common sense, and hopefully somewhere through the discussion some sense will distill through. These are my conflicts of interest, and as you know, I come from Nottingham, and Nottingham's got a number of things that it's famous for, but one of the more important things is that it hosts the oldest public house in the United Kingdom, or England at least. And my friends and I have spent many a happy hour over there sorting our fluid balance out, and at the end of the hour, it probably does us some good because we're perhaps in a slightly better mood, and you have a good diuresis as well, and there's very little salt in the fluid that we drink. So this talk is largely based on two recent documents. One is the NICE guidelines for intravenous fluid therapy in the adult hospitalized patient, and the other is a book that we wrote for medical students. So when we prescribe IV fluids, we need to ask ourselves the one question, that is, why are we prescribing it? And there are three possible answers to that. There's resuscitation, maintenance, and replacement. We all know what resuscitation is. When there's an intravascular volume deficit, we want to give a fluid that stays in the intravascular compartment as far as possible, restores cardiac output and oxygen delivery to the tissue. Then there's replacement, and the typical example of this is a patient who has an aerodigestive fistula where they're losing fluid and electrolytes through the fistula. And for these patients, you give them the maintenance requirement plus like for what is being lost through that fistula. And most patients just need the maintenance requirement, which is much less than we think it to be. And the ultimate aim of all fluid therapy in hospital is to get the gut working and let the patient eat and drink, because the gut, along with the kidney, is probably the best organ to maintain fluid balance and regulate fluid balance. Now, we must remember that there is a dynamic relationship between these three indications, and the patient can move from one to the other fairly rapidly. So, for instance, if we get a patient with multi-system trauma and we've resuscitated the patient, taken the patient to theatre and stemmed the bleeding, that patient moves over from resuscitation to maintenance requirements fairly rapidly, and it's fallacious to give the patient several liters of fluid every day for maintenance. Similarly, if I've done a straightforward operation, that patient should be in maintenance requirement, but if the patient has a postoperative bleed, then he or she moves from maintenance to resuscitation requirement, and we may have to give the patient fluids or even take the patient back to theatre. And then in the resuscitation scenario, this is Jean-Louis Vincent's algorithm, which says there's a salvage state where we're trying to save the patient's life, and then we optimize the patient, stabilize the patient. And finally, once all this has taken place, the patient is usually in about 12 to 20 liters of fluid overload. And then we need to do a de-escalation phase where we get rid of all this fluid that the patient has accumulated in ICU and restore organ function and facilitate discharge of the patient from hospital. So I've already mentioned that along with the kidney, the gut is probably the best regulator of fluid balance. And we understand this because every day about 7 liters of fluid flows across the small intestine, and we only pass out about 150 mils in feces. So if the gut works, use it, not only for nutrition, but also for fluid therapy. And there's very little reason for a large number of patients to be on IV fluids if the gut is working and they're able to drink. So the daily requirements are much less than we think them to be. For the average person, it's about 25 to 30 mils of water per kg per day, and for a 70-kilo man, this amounts to anywhere between 1.75 and 2.25 liters per day. The sodium requirement is very much the same as the potassium requirement, and is about 1 millimole per kg per day. And then we need a minimum of 400 calories, that's about 100 grams of dextrose, not for nutritional purposes, but to prevent starvation ketosis and to also provide some fuel for the brain. We often forget other electrolytes such as magnesium and phosphate, and These are quite important. The amount that we require every day is quite little. You need about 8 to 12 millimoles per day of magnesium, and you need about 20 millimoles per day of phosphate. Now, we don't know what happens if we don't supplement this to a patient who's on 2 or 3 days of IV fluids, but if you've got a patient with prolonged starvation, those patients become at risk of the refeeding syndrome. And if you have a subclinical refeeding syndrome where you have a biochemical abnormality and you start feeding those patients without taking adequate precautions, you can precipitate a full-blown refeeding syndrome, and sometimes that can even result in the death of a patient. So it's quite important to look at these things, but for the average patient who just needs 2 or 3 days of maintenance requirement, we really don't know whether this should be added or not. Probably yes, but very few of us actually do it. Now, we've already seen this in the morning, and Peter Karuni gave an excellent lecture on balanced and unbalanced solutions. So I'm not going to go over the details of this again. But there are some newer solutions that have come out, and you can see over here, these seem to be quite suitable for maintenance. You've got about 40 millimoles to 50 millimoles of sodium per liter. There is enough potassium to supplement the daily requirements, and the chloride load, again, is not very high. Plus, some of these solutions have got phosphate, some have got magnesium, and they've also got buffers in the form of lactate or acetate. They do contain glucose. The 5% glucose is probably the correct amount to give. The 10% may be slightly hypertonic, and if you give it through a peripheral line, that may cause a bit of irritation. But these are newer solutions. Again, whether they are actually of any good, we've got to wait because the evidence is not available at the moment. But on physiological principles, they seem to be good solutions for us to use for maintenance. And because there is no ideal maintenance solution, we often have to mix and match to provide the 2 to 2.5 liters per day that the patient needs, along with the 70 millimoles of sodium and the 70 millimoles of potassium. And these are some mix and match recipes that you can use for maintenance fluids. So you can see here that this 0.18% dextrose in 4%, 0.18% saline and 4% dextrose, which gives about 30 millimoles per liter of sodium and chloride. And it also has 40 grams of dextrose, and then you've got plasma-like maintenance, 0.45% saline, and 5% dextrose. And you can mix and match these with other solutions to provide the daily requirement to patients. You've got to be a little careful in the obese patients because you can't go by ideal body weight or actual body weight, but you've got to adjust the prescription accordingly. And sometimes you need, especially for the juniors, a more senior person to take charge of prescription in the obese patient who's had surgery. And very rarely do the patients actually need more than 3 liters per day unless they're having ongoing losses or they have an intravascular volume deficit. Again, for the high-risk patients, consider prescribing less fluid. And here we have the elderly patients or patients with cardiac or respiratory comorbidity. And we may start with a lower dose at about 20 to 25 mils per kg per day, and then increase that if necessary. And again, when we're not in hospital, we drink mainly during the day. We don't get up at night to drink unless we've had a lot of alcohol that evening. So again, there is a move to try and give patients IV fluids during the 12 hours of the daytime and let them sleep peacefully at night. But again, there's no real evidence that this is of benefit and that it doesn't cause any harm. But hopefully this would be the area of study for the future. When prescribing IV fluids, we've got to take into account all the other fluids that patients are being given. So for instance, if patients are getting antibiotics, some of the antibiotics have a fairly high concentration of sodium in them, and we've got to take that into consideration. We've got to look at IV nutrition because if a patient, or even enteral nutrition, if a patient's getting 2 liters of nutrition either into the veins or into the gut, that's fluid as well. And so it's fallacious to give that patient 2 liters of nutrition and then come and add another 2 to 2.5 liters of intravenous fluids, because then surely we'll be overloading those patients. And this is the recipe for providing the daily maintenance requirement. This is how we mix and match, but even after mix and matching, you may not always achieve the right amount of potassium. And one of the problems in the UK we have is that the National Patient Safety Agency does not allow us to add potassium to balance crystallized. So we can't add it to plasma-light maintenance or plasma-light 148. We can only add it to 0.9% saline or 5% dextrose or 0.18% saline and 4% dextrose. So we are a bit limited from that point of view. Again, for replacement and redistribution, we've got to look at what the patient is losing. So as I said, There are tables available which give you the approximate electrolyte content of various parts of the gastrointestinal tract. You can measure the volume, and then you can prescribe fluids to replace the electrolytes and the volume that the patient is losing and add that to the maintenance requirement. And especially for the juniors, if the patient becomes too complex, then you need to seek expert help, because sometimes you may have to prescribe diuretics, sometimes you may have to give inotropes, and when the patient moves from maintenance to resuscitation requirement, that patient may need to move to a higher level of care, such as a step-down unit or a high-dependency area. I've already spoken briefly about the malnourished and refeeding issues, and we have to be aware that the refeeding syndrome exists. We need to know how to recognize it. And patients who've been starved for 5 or 6 days are definitely at risk of the refeeding syndrome. And before we feed them, we need to give them thiamine, phosphate, and magnesium, and also check that the potassium is normal. So these are all the organ systems that can be affected, and this is the electrolyte content of various parts of the gastrointestinal tract, and you can get this in any textbook, and so it should be quite easy to prescribe fluids for patients who've got GI fistulae. We touched on this briefly in the morning, so I'm not going to go too much into detail for this, but again, we should try and avoid using high chloride containing solutions. There's certainly no place for them in maintenance, because if you give even 2 liters of 0.9% saline, you'll be giving 300 millimoles of sodium and chloride, which is 4 times the daily requirement. I'll skip this. Now, we'll briefly talk about perioperative fluids, because that's where most patients need maintenance fluids. And it's important to realize that we need to get the patient into theater in a state of adequate hydration. Although most anesthetic societies recommend a 6-hour fast for solid food and a 2-hour fast for clear liquids, even nowadays patients starve for 12 or even 24 hours before an operation. And so when they come to theater in that state, they're already in a state of fluid deficit, and when the anesthetist has to put the patient to sleep, you lose vasomotor tone, and so the patient can become hypotensive, and you're already playing catch-up before the operation has even started. The same thing happens with bowel preparation for colonic surgery. There's no evidence that bowel preparation actually does the patient any good, but what it does, it puts the patient into a 2-liter fluid deficit, and once again, you're playing catch-up as an anesthetist. So we've got to make sure that before patients come to the anesthetic room, they're adequately hydrated, either orally or intravenously. And then we did this experiment many years ago, where at that time patients were getting a lot of intravenous fluids in the postoperative period, so we randomized patients having straightforward colonic surgery to receive what was then the standard regimen, which was at least 3 liters of water and 154 millimoles of sodium per day. And then we had a restricted group that got no more than 2 liters of water and 75 millimoles of sodium per day. So essentially, this was 2 liters of dextrose saline with added potassium. And all through this experiment, patients in the standard group got far greater volumes of fluid and quantities of sodium and chloride than those in the restricted group. There was no significant difference in urinary sodium excretion or urinary output. But at the end of the experiment, if you consider that the weight of the resected bowel was about 1 kilo, patients in the standard group were in a state of 3 liters positive fluid balance, whereas those in the restricted group were in a state of 0 fluid balance. And this matched quite nicely with the fluid balance charts that we had. And when we measured gastric emptying time on the 4th postoperative day, we found that both solid phase and liquid phase gastric emptying times were significantly more prolonged in the standard group than in the restricted group. And this is the first study in humans to show that acute salt and water overload can be a cause of acute intestinal failure. And then Brandstrup and co-workers in Denmark did a much larger study, again in patients having colonic surgery. They had a fairly complicated fluid prescription regimen, but to simplify matters, those in the restricted group got fluids prescribed to maintain constant body weight, that's a state of 0 fluid balance, and those in the standard group got fluids to gain about 3 to 7 kilos during their stay in hospital. Patients in the standard group had twice the number of complications as those in the restricted group. There was a greater mortality, but this was not statistically significant. And interestingly, when they broke this down according to the amount of fluid that the patients had actually received, the results were quite startling. So if patients received less than 3.5 liters on the day of the operation, the complication rate was in the range of 20%. But if patients received more than 5.5 liters, the complication rate went up to about 60%. Similarly, if patients were maintained in a state of 0 fluid balance and didn't gain a significant amount of weight, the complication rate was much less than if they gained more than 2.5 kilos in body weight. So far, so good. Restricted good, standard bad. And then we get this paper from Glasgow, which again had restricted and standard colonic surgery. However, when you look at the amount of fluid patients received on the day of the operation, 2.75 liters versus 2 liters, statistically significant difference, but you've got to ask yourself if 700 mils makes a clinical difference. And the answer is no, because the weight gain was minimal in this group and the weight loss was minimal in this group, so both groups probably received the right amount of fluid. And when they looked at all the endpoints, there was no significant difference. So, because we were the first ones to get on this restricted bandwagon, I thought it's time for us to correct this confusion, because if you look at all the papers published in the 21st century, one person's restricted is another person's standard and a third person's liberal. So we looked at all the randomized controlled trials, and here are the author's definitions: restricted, standard, liberal, restricted. And then we reclassified it according to the amount of fluid that patients received. So these patients got too little fluid, these got too much, and these got the right amount. And we know from Professor Bellamy's work that there is a fairly narrow range for safe fluid therapy, and that's to try and keep patients as normovolemic as possible. And then we use this concept to do a meta-analysis. So these are complications, and here we use the author's definitions of restricted versus standard or liberal. And you can see here no significant difference in the rate of complications. However, when you turn this on its head and say patients maintained in a state of fluid balance versus those maintained in a state of fluid imbalance, there's a significant reduction in complications in the postoperative period if patients are maintained in a state of fluid balance. Again, when we looked at hospital stay, author's definitions, no difference. Using the concept of balance versus imbalance, you get a 3-day reduction in hospital stay if patients are maintained in a state of fluid balance. So how much is too much? Well, having looked at both the animal and the human literature, we've come to the conclusion that most patients can tolerate a slight fluid overload. So 1 kilo, 1.5 kilos probably doesn't make much of a difference. But when they start gaining weight by about 2.5 to 3 kilos, they start developing edema as well. And edema is bad for surgical recovery, and that's when they start getting complications, and that prolongs their stay in hospital. So we spoke about the de-escalation phase, and you'll all be familiar with pictures like these. And the study from New Zealand showed that in the first 48 hours of resuscitation of a septic patient on the ICU, patients can gain up to 12.5 liters in total body water. And most of that is in the interstitial space, and they manifest with edema. And it can take up to 3 weeks for patients to get rid of this edema and then recover from the whole process. And these are two pictures of the same patient. Here she's in a kwashiorkor-like state, and here she's in a marasmus-like state. And there's actually no difference in lean body mass or fat mass. All that's happened is that she's got rid of all the fluid that she collected under her skin in the first 48 hours of resuscitation. And again, this is a relatively old study, but still it makes the point that weight gain in the ICU is related to mortality. And if you gain less than 10% in body weight, your mortality rate is very low. And if you gain more than 20% in body weight in the ICU, the mortality rate approaches 90%. This probably doesn't happen nowadays because of the improved care in ICU, but still it's a very stark relationship that we need to bear in mind when we treat patients who are critically ill. So what do we do in Nottingham when we get patients back from the ICU? A lot of them are fluid overloaded, and that's sometimes an inevitable consequence of the resuscitation process. And we treat them with low volume, low sodium feeds, whether it's enteral or parenteral, it depends on the patient's state. And we find that while we're feeding them, they lose 10 kilos in body weight. That doesn't mean that our nutritional therapy is rubbish. It just means that they're getting rid of the fluid that they've accumulated. And as they lose those 10 kilos in body weight, the albumin goes up by about 10 grams per liter. Again, this is not a reflection of synthesis of albumin, but it's merely a reflection of reversal of dilution and redistribution of that albumin. And this is something we've tended to do occasionally. So if you have a patient who's fluid overloaded in the interstitial compartment and may have a low central venous pressure, so low JVP clinically, we've given them albumin on the odd occasion, and when you give them albumin, you produce a diuresis, and sometimes you can combine that with a diuretic as well. it works well because you see the urine flowing. Whether it makes any difference to recovery or not, I really cannot tell you. But what we found on an observational basis is that once patients get rid of that edema, they start eating, the gut functions better, and because the splinting of the leg is gone because of the lack of edema, they start walking around and they get ready for discharge. So again, this goes back to the range of safe fluid therapy. It's a fairly narrow range, and too much fluid and too little fluid are equally harmful to patients, especially the elderly patients. And you can see that some of the changes that happen at the cellular level are very similar for the underfilled patient as they are for the overfilled patient. Now, there is some concern that if you give patients hypotonic solutions like 5% dextrose, dextrose saline, you may produce hyponatremia. And usually that doesn't happen if the patient is in health and you're giving 70 millimoles of sodium and 70 millimoles or 60 millimoles of potassium per day. But you can see that in the pediatric group of patients, they are at risk of getting hyponatremia if you give hypotonic solutions, and that's why the pediatricians do not like to give hypotonic solutions. And again, if patients lose skeletal muscle mass, there are huge changes in their body water, and those patients are also at risk of developing hyponatremia if you give them hypotonic solutions. So in conclusion, the choice of fluid should be according to the indication. So the first question we need to ask ourselves when we see a patient is, does this patient need IV fluids? And the answer to that question very often is no. Why should an orthopedic patient need IV fluids? Even after major bowel surgery, most patients are drinking adequate amounts on the first post-operative day. But if the answer to the first question is yes, the patient needs IV fluids, then the next question is, what is the reason? And they can be resuscitation, replacement, or maintenance, and we've got to give appropriate fluids. We should prefer balanced crystalloids to 0.9% saline. But even for maintenance, even balanced crystalloids provide much more than the daily requirement of sodium, potassium, and chloride. And so we've got to get the other solutions, and we may have to adapt these for our patients. We've got to give an adequate amount of free water, and this is best given as 5% dextrose or 0.18% saline and 4% dextrose. And we should avoid salt and water overload at all costs. And if the patient is salt and water overloaded, we should aim for a negative fluid balance in the post-acute phase to aid recovery from the illness. Don't forget phosphate and magnesium. In certain cases, you do need to supplement, especially before you start refeeding. And once we get the evidence, we may be adding these to all our maintenance fluid bags. So we've got to consider ready-to-use balanced solutions that contain all the electrolytes, but sometimes this is easier said than done. Thank you.